Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto, the host of the Medical Society podcast, Delaware Healthcare Reality. We have two guests today, but before I introduce our guests and get to the subject involved, I would like to say thank you to MSD's Health Champions, our corporate sponsors who support making this podcast a reality. They are Peak Technology Associates, Delaware Health Information Network, WSFS Bank, Source Pass. But now, our guests today are Dr. Rama Peri and Dr. Cynthia Heldt. I will give their bios now, and then we will take questions, and we will offer questions to them. Dr. Rama Peri was born in India and emigrated here at the age of 4. She went to college for her undergraduate degree at Douglas College, part of Rutgers University, where she earned a bachelor's degree of science. She then went on to Princeton University and earned her PhD in biochemistry. By the way, I have my master's in biochemistry, so we could talk about the Krebs cycle, maybe. No. She worked on developing monoclonal antibodies against cancer cells. Really enjoyed doing research, as she said, but she liked more patient-related contact. So she applied and went to Rutgers Medical School, and then went to residency in family medicine at Rutgers because she enjoyed primary care and working with all age groups. She met and married her husband, Harry Peri, in 1983 while he was doing his residency and then fellowship in oncology, and she was in medical school. She worked part-time in various settings, including BB primary care, private practice setting, and an FQHC. It was in 2014, after taking time off, she decided to start a clinic focused on uninsured patients. This led to the development of the Rosa Health Center. The clinic's purpose was to focus on the needy and uninsured patients in the community, and it was named after one of the nuns who lived and helped the community. Since 2014, she worked full-time on the clinic, not being paid, and since his retirement, her husband, Dr. Harry Peri, also volunteers at the clinic. She is married with 3 children, as mentioned. Her daughter, Nuru, has become a family practice doctor, and her oldest son, Anand, is an oncologist at present at the West Coast in Oregon. Her son, Kiran, didn't go into medicine, but went into data science and is married with a daughter. Welcome, Rami. Cynthia Heldt is a Delaware native and graduate of Jefferson Medical College. She did her internal medicine residency at Christiana Care. She practiced hospital medicine and primary care in private practice for 10 years and then joined Christiana Care. She retired from Christiana in 2018 and went back into private practice and primary care, and then retiring from full-time practice in 2024. She holds a fellowship with the American College of Physicians and was named Delaware Laureate in 2018. She has volunteered at the Sunday Breakfast Mission Clinic for about 6 years. She enjoys skiing, gardening, traveling, and playing with her grandchildren. Welcome, Cindy. Okay, I'm going to start with you, Rama. My first question is, tell me a little bit about the Rosa Health Clinic.
We began the health center to focus on uninsured patients. The work I had done up until then, I always had felt that patients without insurance needed special attention and more effort. And I wanted to have a setting where I could be in control and have some say in how things were done. And that's where the beginnings of the center started. The center itself is named after Sister Rosa. There were 3 nuns in Georgetown, Delaware, who for 20 years worked with the community. I became very close friends with her because in the office setting that I had worked in previously, she would bring in the prenatal patients for their care, and I got to know her that way. And so when we started the clinic, I named it after her because I wanted it to represent the qualities that she represented in terms of treating the community. So we basically started with charging a very nominal fee for patients and basically a lot of times just writing it off for patients who came in. I'm family medicine, so I was able to see everybody from newborn to the elderly. And we went by word of mouth. We never advertised because the idea was we wanted to have patients who really needed us to come to us.
Understand.
And we're located right in Georgetown, so patients can actually walk to our office. So during the years, I've had many patients, the mothers coming in with their babies strapped on their back, walking to the office. We've had patients literally knock on the door who needed something, and you'd open the door and there'd be somebody with, I had a woman who was delivering. We ended up delivering the baby in the office. I had another mother who came in with her child in her arms, 4-year-old who had the body of a 2-year-old. And to make a long story short, we hooked them up with Nemours, and the child got the treatment that they needed.
Right, nutrition too.
Right, it was a congenital problem.
Okay.
And so because we work with uninsured patients and because we set up the clinic ourselves, we're able to spend whatever time that we need for a patient. And I have a person who's like a social worker in the office, and so she helps connect the patients to resources. So unlike most offices, the ratio of doctor to staff, the staff is a lot more because they are able to help with what the patient needs.
Does your staff volunteer also to do it in gratis, or do they receive a salary?
No, I had wanted to see about trying to get people to volunteer, but I realized very quickly, because I know there have been other organizations that have tried that, it's hard to ask somebody on a regular basis to volunteer. It's one thing for me to do it. It's another thing to ask the staff to do it. So the goal was to generate enough money to be able to pay for the staff. And what I discovered is that by having a balance of insured patients, because we do take insured patients, and a balance of uninsured patients, we could take care of the uninsured patients. So in my office, which is different than any other office, 70% of our patients are uninsured. Okay. 30% are insured.
Got it.
And so I found by trying to keep that ratio, I'm able to generate.
Keep your head above water.
I'm able to, and that's how we've been operating, just keeping our head above the water. But we're able to provide the care to the patients that we want to be able to provide care for.
Very good. How many you see a day? And how many days a week do you work?
Well, in the beginning, up until when COVID hit, we were 5 days a week, and we were seeing about 15 to 20 patients a day. And in the beginning, I had another physician with me. Within a couple of years, she went on to join the VA. And so then after that, it was just me. And she had worked part-time. I had always worked full-time all the way through. When COVID hit, we had to change because the advantage of being a small clinic is we can respond to community needs very quickly. And so when COVID hit, we needed community screenings. And so we were able to make a decision, we're going to do it. And so we could do it right away. And so we purchased our own PPE, the equipment needed and stuff like that. But the tests I had to get from the state. But I had already volunteered with the state doing other things. And because of that, I was able to ask them to give us some tests. At that time, tests were like gold. Mm-hmm. And so we got 30 tests.
Nice.
And we were guarding them. And so we did the first community screen by a community organization, not the hospitals and everybody, but we were the first one in Georgetown to do it. And we had 100 people show up, more than 100, but I had to pick and choose who we were going to test.
Right.
And
by symptoms, maybe?
By symptoms, temperature, they had to be really sick.
Got it.
And so we would have whole families show up, but we would test maybe one who was the sickest and then presume that they had it too. And what happened is, out of the 30 tests that we did, 27 came up positive.
My God. Wow.
And it was, and I'll never forget the results coming on our printer. And I thought, oh my God, I made a mistake. I didn't process the samples well, because we didn't expect a ping, ping, ping,
right.
ping, one after the other.
Right.
And 27 out of the 30 came up positive.
I hope you didn't get it yourself, did you?
No,
okay, great.
we were,
you were protected.
I was really good all the way through.
Oh, great.
But because of that, we decided to take one full day and one half day out of our schedule to do screenings.
Okay.
And also at that time, because of COVID precautions, we had to see patients in a different way.
Correct.
You couldn't have 20 people or 15 people sitting in the waiting area.
Correct.
So we had to do things different. So, but we spent all of our time for a whole year doing screening, and then we converted to giving vaccinations.
Very good. Okay, how do you afford supplies, and do you supply medication?
Supplies, I'm Scrooge. I'm very careful about how I spend, and I'm serious about this. The equipment, if you had seen our office, was all hand-me-down stuff. We got our one exam table was left there by the previous provider. Mm-hmm. We scrounged up to exam tables from somebody that was closing. BB was generous because they were remodeling. They had extra lab tables, so we got tables from them. Our desks were from the thrift store, $5 a desk, and whatever furniture was left there, that's what I used from the beginning. Mm-hmm. Then, as we progressed, and as we needed things, we would purchase whatever we needed. So up until maybe about 2-3 years ago, I had the same stuff all along. And then as we started getting some money, doing like Screening for Life, where we do female exams in the office and the stuff, and the state has a program. So if you participate and you do that, the state pays us a fee. So we generate some money that way. Mm-hmm. And so with that, we were able to get equipment and stuff like that. In the last couple of years, through a COVID grant, we were able to upgrade our exam tables. My staff got tired of me duct taping all the chairs, and so we finally got some new chairs just for the exam rooms, not for anywhere else.
I gotcha.
And I keep telling them, just wait. When we move into the new building, we have money that we are saving, so that when we move into the new building, then we'll get equipment.
Okay, how about meds? They're very expensive.
Right, so meds, I was a big fan of the $4 Walmart formulary, which no longer exists. Right. But we applied and we participate in a program called 340B, which when we write a prescription, theoretically, the pharmacies that participate, it's a discount for the patient. It works sometimes, it doesn't work sometimes, but sometimes some of the extremely expensive medications can be cheaper on a 340B program.
Do you see pharmaceutical reps?
Until I have a nurse practitioner in the office now, Anna, who's wonderful, and until then I did not. But she came with patients she had been working with patients with insurance, and so I never used to call the drug reps because I felt guilty, because I knew that my patients wouldn't be able to afford their medications. But since now we're developing, balancing, keeping the 70-30 ratio, but we're developing an insured population that will use the medications that we can write the prescriptions for. We now have drug reps coming in, and what's been wonderful about that, a lot of them are able to tell us about programs that we might be able to use for the uninsured patients.
Well, in my practice, I see reps, and they leave a fair amount of samples, and I tell them, please leave a sample. And they do, in most cases, in some of the medications. So it's good you're seeing them because they may help you out, and their companies are well off enough to help you gratis, I'm sure. Give us your address. I want to know your address so we can generate information to go that way.
It's the Rosa Health Center, 10 North Front Street, Georgetown, Delaware, and the zip is 19947. Our number is 302-858-4381.
Okay, so this is a way I want that to get out there. I want people who have good hearts and realize that you're doing good work for the poor, for those that are uninsured or can't afford it, may be able to donate to your foundation. And that's what I would like to see.
And I can tell people anything that they donate, if they specify something, we will use it specifically
for that.
Especially for that.
I know that the Medical Society supports you in ways. DFMS, that's our Delaware Foundation for Medical Services, also supports you with some money, and as well as subsidizing your malpractice because, as you know, malpractice can be expensive, and it'd be unfair to have to pay malpractice when you work for nothing.
The first couple of years that we started, I didn't have the money. We literally just started this. Not knowing anything about business, not knowing anything about a practice. All we knew is we wanted to open the door and see people. And then the reality starts hitting you of what the different things are. One of them was the malpractice. And that was a big chunk that I didn't have the money for. And the Medical Society from the get-go has been helping us.
We're pretty good guys, aren't we?
Yeah.
Okay. That's what we like to do. We like to support the ones in need, and we have a lot of patients and people that don't have any money. And I have, many times in my practice, did not charge a patient when I knew that they could not afford it. And I'm in a VIP program. I don't know if you know what that program is we see people and we accept the payment on a sliding scale. Most of the time the scale slides away and I let them go out the office without having to pay. Okay. Now, we talked about your affiliation with hospitals and how the cost may be, when you see a critical patient that has to go to a hospital, that the cost could be oppressive to the patient. So are there ways, I know you said that hospitals are all different and they'll work it out and this and that. Do they get patients Medicaid if they go to a hospital uninsured?
This is what we've started doing in our office. And it's, a process that we've developed over the years by learning. So now the person in my office who helps enroll people in the Screening for Life, the HCC, the programs that just you were talking about, she also helps patients apply for patient financial services.
Great.
So at the hospitals, the hospitals have been great, so that when we apply for this way we give the patient a leg up. So they've got this going already for them. So if they have to go to the hospital, they've got this, we start getting that. She starts that process when they come in. And so, and for emergency Medicaid, whatever we can do, we try to help them. And the reason why in this setting it's important to have somebody like her, a lot of my patients don't read, don't write, and the applications can be daunting. Mm-hmm. I mean, for us, it could be daunting. So for someone who might have a second grade education, it would be very difficult. Mm-hmm. So she sits and she spends the time, and whatever resource we can connect the patient to, we do. But that's where the hospital helps. And then there are times, for example, a couple of years ago, the place where we normally send our pregnant women to for pregnancy care, for about 3 months, they didn't have the provider to be able to see the pregnant women. Mm. So, and all of a sudden we're getting calls from women who are pregnant who don't know what to do. So I called BB, and I spoke with their OB department, and I called them because they were the closest at that point, and they've always been helpful. Tidal Health has always been helpful to us, Christiana Care, Nemours, and I called their department, and we made an agreement because they won't see patients unless they have a primary and they're established. And so we established the patients.
You became their primary.
We became their primary. Mm-hmm. I did the first visit, did everything, and then we referred them to BB, and then BB took over. And it worked great. For about 3 months, we saw maybe 25 women. And then after that, the other provider, they had the provider, and we were able to send them back over.
You are doing a tremendous service down there, and it's fully appreciated. I think you have a straight stairway to heaven when the time comes. Okay?
Oh, no.
Oh, yeah.
And I need to put a plug in for my husband.
Go right ahead.
Dr. Rama Peri. He started the oncology program at BB.
Uh-huh.
And he also is volunteering full-time.
I mentioned that earlier. Mm-hmm.
Also free.
Okay.
So he's my free slave labor, but his ethics and how he practiced are the values.
Very
also.
Good. All right, before we introduce and talk with Dr. Heldt, Cindy, I think we should take a short break. Any questions, comments, or concerns you have about this podcast, or possibly any ideas you may have for future podcasts, please send it to our email, which is healthcare.reality@medsocdel.org.
The Platinum Dining Group is a full-service hospitality group based in northern Delaware and founded in 1996. They are a company that believes the very fundamental truth that no task is too great and no detail too small. Eclipse Bistro, 7 restaurants, and any event catering company and a fine goods retail market now reside under the PDG umbrella. They strive with one guest at a time to offer a complete and rewarding hospitality experience. We're pleased and proud to have Platinum Dining Group as a sponsor of the Medical Society of Delaware's podcast series.
I'd like now to talk to Dr. Cynthia A. Cindy, I know that you work, volunteer your services to the Sunday Breakfast Mission, which is located
at 110 Poplar Street
in
Wilmington.
Very good. Now tell me a little bit about how your clinic works.
I think of our clinic as sort of a cross between an urgent care center and a nurse's office in a school. Mm-hmm. We're just there 2 hours a week, 5 to 7 on Tuesdays. We have about 22 volunteers that come in. The Sunday Breakfast Mission is a homeless center. Last year they had 76,000 overnight guest nights there, so it's very well attended. They have 298 beds, and sometimes they're at over capacity. They see men, women, and children. and we just open our doors and see whoever comes in. Typically, we have a team of 22 volunteers. Of that, 3 physicians.
3 of them are physicians?
3 of them of
okay.
that are physicians. We're all retired there. We've have some nurse practitioners, a lot of RNs, and then we've had a variety of everybody else who we've really enjoyed getting to know, including nursing students, 4 medical students, 3 high school students, some middle school students, and some people outside the profession.
Wow.
So
You've got a great staff.
We've been lucky with our recruiting there. It's really been fun. We try to have 3 people working at the same time. One, hopefully somebody licensed to prescribe, and 2 nurses usually, and then we'll usually have, we've had some very dedicated high school students who've been filing things for us and helping us with putting Tylenol into bags so we can dispense it, and kind of crowd control outside the office there.
With that population that you have, is 2 hours a week enough?
Probably not. We try and get everybody to have a primary care doctor. I mean, that's a huge thing to try and find for people. It's the drumbeat every day. We're there. Please make an appointment at Westside Clinic, St. Francis, Christiana Care. But a lot of people are coming from someplace else there. They're just kind of passing through. I ran out of my seizure medicine because I just got out of jail and I didn't get a prescription. Or my last doctor was at Rutgers and I had my diabetic medicine. I haven't had it for 2 weeks, or those kind of things. So we're filling a lot of holes that way.
You know, with 3 doctors, you said 3 doctors are staffing it, as well as some nurse practitioners. Couldn't it meet more than 2 hours a week?
Well, it's not 3 doctors there at once.
But I mean, say, doctor take Monday, doctor take Tuesday, doctor take Friday.
Well, I don't think people right now are willing to do that. And they use that space for other things, too. We're really working in 3 closets.
Okay.
We don't have an exam table. If I examine somebody's abdomen, they lie on the floor.
And how are you getting funded?
We don't charge. Last night, I opened a box of non-prescription medications and socks and things from Sanford School. It had a bill on it with $471. We have some of our volunteers have contributed to funds to buy non-prescription medications there. Things get provided somehow.
God bless them. Okay.
And we also get our malpractice as retired physicians who've already taken our tails. We are funded by DFMS as well for our malpractice.
Okay.
Our other staff does not have malpractice right now.
That's concerning, I think. I think that would be concerning.
Nurses and things. So.
I think so. What's the best case scenario for your clinic? What would you like to see develop, if you might have that in your mind?
Well, some things have to do with acquiring pharmaceutical medications. A lot of times, it's an interesting distribution of people that you see there. Recently, we see a lot of pediculosis. We see dental emergencies at least once a session. We usually send somebody to the emergency department once a session. And we do a lot of reassurance as far as things being okay. Yes, this back pain, here's some exercises, some Advil or Tylenol. Yes, your blood pressure is okay. Yes, we'll be happy to change the dressing on your wounds for you that you haven't had changed in a long time, and we can give you some bandages and things for that. I'd love to develop a way to give people coupons for prescription drugs that they could get filled at a pharmacy if we could get a fund for that, and a pharmacy would agree to that. I don't even know if that's legal. expanding it to a larger proportion of days would be helpful. But the real issue is there's such a delay, and you know this, in getting people primary care doctors in Delaware.
Even if you're not
homeless.
Not needy or homeless, it's tough getting a doctor.
It's a big delay.
Mm-hmm.
So, we are definitely a safety net kind of institution there. I think we do good, especially for the people that end up going to the emergency room when we see them, infected wounds or had one guy with COVID and DKA. We had somebody with a pulse of 32 from an overdose that we gave Narcan to. Those were helpful in some cases, but being there more would definitely be helpful.
Interesting.
Even if we could get more laundry facilities for homeless people. I can't get rid of lice. People don't have any place to wash their clothes.
Right.
It's really a sanitary thing. That's.
Have you appealed to the state to help you out?
Well, there are state partnerships. There's a lot of people in Wilmington who have practiced medicine out of vans. St. Francis has a van.
Right.
The state has a van. Private physicians have a van who have done a lot of work in the community with drug abuse. But they're not always in the same place. They're not always in the same place at the same time. We get a schedule sometimes of where the vans are going to be, but we're in the same place once a week, so people at least know. Oh yeah, I can go see those people will help me out. I can get my Advil from them. I can get some skin lotion from them. They'll usually give me another pair of socks, so we can be at least a consistent way to go with
I would like to see your clinic open 5 days a week, like we have it at the Rosa.
We need more people. We need more doctors.
More doctors.
And there is a problem with getting doctors to get malpractice insurance. We've had people come by and look at our clinic. Many people who would like to help can't because of that. If you work for the state, you don't get to volunteer and have your malpractice covered, apparently. I've had several doctors who do a lot of good work with a similar population in this state who haven't been able to work in this setting. Also, if you work for a bigger practice, a lot of times people are discouraged from volunteering in this setting because they won't cover their malpractice insurance.
Well, doesn't DFMS help you with your malpractice, or it helps you with the malpractice?
It helps me. Well, they give the money to the Sunday Breakfast Mission, and they pay our malpractice. But we have very low malpractice because we've all taken a tail. So my malpractice is just for somebody doing volunteer work. And having taken a tail with my malpractice, I can do volunteer work, I can do teaching, I can do clinical work, but not for pay. So that's the limitation.
Well, wouldn't that also apply to those docs who came in? You said you had 3 doctors. Wouldn't that apply to them in a similar way?
Yes, and they get it that way too. Okay. So I can recruit retired physicians who've taken a tail.
Okay.
So and people in private practice.
There's
many people who work for larger institutions now, and their insurance, they're discouraged by their practices from doing volunteer work, is my understanding from people who come.
So let's say I retire, and I say, Cindy, I'd like to come and work there.
And you take your tail, your malpractice.
I bring the tail with me. The rest of it's covered by something, DMFS, I guess.
Yeah.
And then I would say, I would like to work different hours than you so that you could see more people that need it. In other words, 2 hours a week with what you see.
Yeah, the folks aren't there during the day. They have, at the Sunday Breakfast Mission, they have a residential program, which is about 40 men, which is a Christian-based basically detox program where they have many rules. They have to take classes on jobs. They have to take classes on good work performance habits. They can't leave except to go to work. They have to do certain things to get through that program. In the meantime, they have a place to stay there during the day. But everybody else only gets admitted at 6 o'clock at night, 5 o'clock if they want to come see us in clinic. And they have to leave by 6 o'clock in the morning. And the rest of the time, they're cleaning the place and getting ready for dinner and getting ready for breakfast. And all that's done during the day there.
And I guess no drug reps come along to drop you off some samples. No. Is that a possibility happening?
Well, there's a lot of overhead. We have a cabinet where we lock our records and our non-prescription medications, things like Tylenol, Advil, Nix.
Yeah, you must have a lot of that.
That's really expensive,
Ain't cheap.
It is expensive. Many problems.
I'm a big proponent of a one-party payer system in this country and how that would work, i.e. Medicare for all. Call it what you will.
Yeah.
But the insurance lobby is so great, that's going to be hard to put through because they're going to oppose it because they make a lot of money in this situation. However, I feel as if you want to keep the capitalistic attitude, divide the country up into 4 parts. Highmark do East Coast, somebody do Central, somebody do Mountain, somebody do Pacific, and give them a certain amount of money from the government and let them run the programs on, for example, the East Coast Highmark. You run out of money, then you've done something wrong and you don't get any money in return. You see what I'm saying? Something can be worked out that we go on a system that is both, fair and also all-inclusive, because those individuals who have no insurance can get Medicare for all right off the bat. In other words, if you're born, you get Medicare for all. We don't have to deal with the idiosyncrasies of each of these insurance companies, especially me working in an office and trying to get this done, that done. This prior authorization is different than this company's prior authorization. It's so burdensome to both the doctor and the patient. So I'm a big proponent of Medicare for all, and I want to say that and put it out there and let the government pay. I imagine through taxpayer monies or whatever grants they can get somewhere else, but just to have it work and to make it less burdensome, and also then give you the opportunity to have somebody come to you that has Medicare, and you'll get some reimbursement in turn and build your clinics. That's just my feeling. I'm reading a good book by a Dr. Troy and Brennan on the insurance industry, and he's a big proponent also of Medicare for all. One of my previous podcasts with Dr. Damien McHugh, who's British-born, trained in Britain and then trained in America, and became an emergency room doctor, recommended that book. It's a great read. Troy and Brennan, if you remember that, you could pick up that book and see where we're going with the future of medicine and coverage for medicine in this country. I don't see any big changes for probably a decade or so I may not even be around to see it, but I think that's important to justify and allow people that have no insurance stay as healthy as possible. So, anything, Cindy, you want to add to helping you help them?
We need more dentists in Delaware.
We need more doctors in Delaware.
We need more doctors.
Do you have dentists that will work with you?
There are dental clinics that we can refer people to.
Okay.
The Wilmington Hospital, and there's a Pierre Toussaint clinic downtown too.
So they get their dental care. I imagine their oral health is not very good.
No, I would say, as I said, probably 10% of the people we see have some type of dental issues.
And they get
that are painful and urgent at the time that they get in to see me.
Okay. Ladies, it's been very interesting speaking to you, and I want to put this out to the people that are listening. If you have the means and you want to donate, you can donate to the individuals that need help. You can donate to these two doctors who run clinics. You can donate to DFMS, who in turn will distribute monies where needed for the individuals that don't have insurance and are suffering on a daily basis. There, by the grace of God, go I. So I think you have a stairway next to her to walk up and go to heaven too. God bless you both. I'm happy to have you here. This is Dr. Nicholas Biasotto completing our very interesting podcast with Dr. Rama Peri and Dr. Cynthia A. Please give every consideration to donating to their organizations.
Thank you.
Thanks.
Thank you.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.